Right. This is a very introductory talk about angiographic views and how to recognize the different views on coronary angiography, the basic coronary. Now, I thought there's more to it, way more to it than just angiographic views that people need to know on starting to get into the Cath Lab for diagnostic angiography. So what I'll do is I'll start with a few basic things. It won't cover everything, this talk. We can then subsequently go into further detailed talks in the future. I'll also answer your questions at the end. So if you have any questions, please bear with me, and then we'll see if we can cover everything in the end. So Cath Lab, I still don't know how many of you have much idea about what gets done in a Cath Lab, what a Cath Lab is. I presume you are at different stages. Some of you are experienced in Cath Lab, others may be starting, and therefore I'll just cover the basics fairly quickly. And I hope I'm not giving you too many basic information or too much basic information. So the Cath Lab team, it's a significant team. You don't have all these people in the Cath Lab. Usually you need a few of them, but you need a cohesive team, a team that understands each other and works well with each other, and that would ensure the best outcomes for any procedure. Now, what I will cover in this talk is very quickly again, procedural indications and risks. So why we would need to do angiography, operator and patients, appropriate equipment in the Cath Lab, appropriately trained staff, and of course safety aspects, and focusing on puncture techniques, osteal engagement, why it's important, and of course image acquisition techniques, and finally angiographic views, how to recognize each views, what to look for, how to recognize the different vessels, and then we'll get into questions. As I say, this doesn't cover everything about Cath Lab. There's a lot more that needs to be covered, but one talk can't cover everything in Cath Lab. Now, going on to why we need to do angiography, why we would need to do an angiogram to anybody. There are elective indications and urgent indications. Summing them up, the elective indications would be things like persistent angina pectoris, meaning somebody who's getting exertional chest discomfort, and that would be persistent, meaning it is recurrent and happening or worsening. And evidence of significant reversible ischemia on stress testing, like MyoView or exercise treadmill, or cardiac MR scan, with or without symptoms. Often it would be with symptoms, otherwise the test wouldn't be done in the first place. And of course, we would do angiography prior to considering valve replacement surgery or any form of cardiac surgery, meaning non-coronary surgery. If anybody's having, for example, an aortic valve replacement, we would need to do an angiogram beforehand to ensure there's no coronary disease to request or to necessitate bypass operation along with the valve replacement. And of course, there are urgent indications like ST elevation, myocardial infarction. This is an extreme emergency, and non-ST elevation, myocardial infarction, and in the midst of investigating some unexplained heart failure or left ventricular dysfunction, that could be semi-urgent indication for it. So these are mostly the indications. There are some other indications, of course, but as I say, this talk doesn't cover everything. It just covers the basics. Now, coronary angiography doesn't come without risks, and I'm sure you understand a procedural risk of a procedure doesn't mean that it must happen. The risk is the probability of something happening, and we'll cover the most important risks. These are the serious most risks, which, and of course, a serious risk doesn't mean that it must happen or it will happen, but it is rare, and by rare I mean it is quantified at anything between 1 in 500 to 1 in 1,000 of potential possibility or probability of it happening. And if it happens, it can be serious. And these risks include death, myocardial infarction as a result of a coronary dissection, for example, stroke, whether it be a bleed or an embolism, CIN, that's contrast-induced nephropathy, because contrast can potentially harm the kidneys, and of course radiation burns, if these if procedure is prolonged with a lot of radiation. But there are other smaller risks, but these are the most important serious risks that you need to quote when you are consenting a patient, because patients, before they undergo coronary angiography, they need to sign an informed consent. So before any invasive procedure, and coronary angiography is an invasive procedure, patients need to be aware that these risks exist, because they might decide to change their mind. After all, it's them who are doing the angiogram, not us. Now, the equipment that we need to have in the cath lab, again, very quickly, you have an X-ray image intensifier or image acquisition device. This is the C-arm, we call it. You need sheaths, different sheaths, femoral, radial, wires, J-wires, angioplasty wires, and different shapes and forms of catheters, diagnostic and guide catheters. You need, of course, drugs, which we didn't include here, but there are plenty of medications to give. And ensure the availability of echocardiography within the cath lab. You need an echo machine, a portable echo machine in the cath lab, in case you need to test for the development of tamponade or valve abnormality, etc. Also, you need, of course, the staff members, interventional cardiologists. If you're not the cardiologist yourself, you're a trainee, maybe the cardiologist would let you do the procedure if you're experienced enough, but he or she should be in the vicinity around just in case you need their help. PCI wires, stents, guide catheters, etc. These are the basic equipments, and there are plenty of others. Am I sounding clear so far, Dr. Hatim?
So clear. تمام جدا Dr. Talal. We are so enjoying it.
Thank you very much. And the cath lab staff, which I alluded to earlier on, you need one operator, that's the lead operator who's operating, and you need a physiologist. This is the person looking after the hemodynamics, the transducers, the hemodynamic screen, the blood pressure, the saturation, the ECG recording, and you need a radiographer who would be operating the X-ray, the table, positioning and moving the image intensifier to various positions. Sometimes the radiographer and the physiologist could be the same person. Where I was trained in the UK many years ago, I was the operator and also the radiographer moving the table and the screen. So, but you do need people to operate the X-ray equipment and the table, and also people to operate the hemodynamic transducers and ECG and the saturation monitoring. You also need 2 nurses, 1 runner and 1 second scrub. So 1 scrub nurse, preferably, not essentially, but preferably would make life easier for you if you have a scrub nurse with you. And a runner nurse who would go and get the equipment that you'd ask for. Of course, you need a consultant to oversee everything. And moving on to the puncture tips and pitfalls. As you know, there are 2 main techniques for coronary angiography. When it started first, you may not know, or you may know that when it was first devised, coronary angiography, they used to do it via the brachial artery. They didn't start with femoral. Femoral came later. And then it became the predominant route for a long time until the early, maybe late 90s, when the radial route started to take over. And it became the preferred route for procedural intervention for many interventional cardiologists. And for a variety of reasons, radial route is safer in terms of vascular complications, but it can be fairly more challenging specifically if you're not quite used to doing radial procedures. Femoral procedure, on the other hand, doing the femoral angiography is easier to gain access to engage catheters, etc. But it can cause more serious complications in terms of vascular access complications. And regardless of whether it's a femoral or a radial access, you need a safe and clean puncture, and you need to ensure how to achieve that. So I'll focus on the femoral because the radial is, as I say, significantly safer. So if the worst comes to the worst and you damage the radial artery completely, you'll still keep the arm. And you won't have a major life-threatening bleed after all, because you can compress it. So radial punctures aren't as serious, nowhere as serious in terms of complications as femoral complications. So I'll focus on femoral artery complications. So looking at the femoral anatomy, I'm sure you're all familiar with the anatomy of the femoral artery, where you actually gain access. The femoral, where you feel the pulse, the femoral pulse is between the anterior superior iliac spine here and the pubic symphysis to the midpoint here, and you have the famous structure, the femoral vein, the artery, and the nerve van. And what you need to do is puncture the femoral artery here, not high up here, and not further low here. And there are reasons for that. Now, if you go high up here, you and the landmark for it, you won't see it, of course, but the landmark for it would be the inferior epigastric artery. If you go above that, then you're too high, and you run the risk of potential retroperitoneal bleed if the puncture is not quite as good or as clean. And I'll explain why. If you go below or too low, you're going to go into the superficial femoral artery here, because then the artery gives rise to the profunda femoris artery. And here, the artery becomes, in terms of caliber, fairly smaller. So if you end up putting a plug-in device like an angioseal, then you could potentially occlude the vessel, amongst other complications. So what you need to do is really try and focus and puncture between here and there. So somewhere here, literally overlaying the femoral head. And so looking at this, if you puncture here where you need to puncture, where you need to puncture here somewhere, you can, subsequent to the procedure, once you try and achieve hemostasis by direct pressure, you can compress the vessel over the femoral head, because that's where you need to be. So there's a bony structure underlying the vessel over sort of upon which you can compress the vessel by manual pressure if need be. Whereas if you go too high here, the vessel dips into the pelvic floor, so it becomes uncompressible. And if there's a bleed, you'll end up with a retroperitoneal bleed. So that's something to avoid, high punctures. And again, low punctures here, if you end up puncturing here, as I say, the vessel could be too low, so and too small of a caliber. So closure devices, particularly angioseals, could be occlusive and could result in limb ischemia and potential gangrene. So you want to avoid that too. And the one simple way of doing it is you simply screen and have a, say, an artery forceps overlaying the femoral head, and where you feel the puncture there, just go in. Of course, with an ultrasound guidance, that'd be even better. Now, moving forward to engaging into the coronary arteries. So you've got your puncture right, you've gone in with a diagnostic catheter, and you want to engage into a coronary artery. So engaging, although people take it for granted, but it can be serious and it can cause problems. And I have seen throughout the years engaging going wrong, people going into VF arrest because of wrongful engagement, closure of vessels, dissection upon the initial injection, all sorts. So be mindful before you engage into the presence of calcium at the ostium of the vessel you want to engage. Be mindful of pressure damping. So once you engage your catheter into the vessel, also have a glance at the hemodynamic screen and see what happens to the pressure signal. If the pressure signal dampens, then you are into a significant stenosis. So be mindful not to engage and have a forceful injection afterwards. There'll be unstable flaps sometimes. So by engaging, you can destabilize a flap and potentially occlude the vessel. If in doubt, if you think the ostium of the vessel, the left main stem particularly, or the right coronary artery is not normal, then do a sinus injection. So inject into the sinus where the coronary artery is arising from. The injection force and timing is also significant, and I'll go through that in a second. How to inject, when to inject once you do the acquisition. So upon pressing the acquisition pedal, pause for a second or two, then inject, then pause, await the dye to partially clear, then disconnect the acquisition signal. That's the best way to achieve appropriate acquisition of a coronary image or a cine image. Now, I'm just going to go into some images. I hope this plays. It is playing. So looking at this vessel, you're looking at the right coronary artery. Now, how do I know it's the right coronary artery and nothing else? First of all, it's mostly one vessel, because this is our guide catheter here. I'll just pause it for a second. This is our guide catheter here, or our diagnostic catheter. And upon injection, you see mostly one vessel running all the way, and it divides into two big vessels towards the end here. Now, the catheter is pointed to the left of the screen, so it's pointing this way, to the left of the screen, right? And it mostly is occupying the left upper side of the screen. The vertebral column, you can see it in the background here. And the rib cage is inclined this way. So this tells me that I'm looking at the right coronary artery, because I don't have any vessel, big vessel arising of equivalent size arising somewhere here. So a single vessel that bifurcates towards the end is the right coronary artery. Now let this play again. Are you seeing any other movement? You'll need to focus on some other movements. You'll see the heart beating, and that is what gives the movement, the jerky movement of the artery as the heart continues to beat. So let's just let it play again. So there is the heartbeats. Just focus on that movement for a second. The heart is beating, right? So at a slower pace, you see some other movement. You see the respiratory movement. You see the rib cage and the lung structures moving up and down. You see those? Just look at it again. There's slower movement, respiratory movement here on this side, here. Just look at it. Okay. So can you see something else? Can you see the diaphragm? You can see the diaphragm here, but it's occupying less than half of the screen. When it's occupying less than half of the screen, then you're looking at a straight view, a straight LAO view. We call this LAO, left anterior oblique view of the right coronary artery. The bifurcation is not clear. So in an LAO, in a straight LAO view, left anterior oblique view, the bifurcation here of the right coronary artery, because as you know, it divides into a PDA, which here, is kind of moving towards us, towards the screen. So it's very foreshortened, this vessel. And the PLV, which is the posterior left ventricular branch, it's there. So the bifurcation here is overlapping. You're not seeing it very clearly. That is what you see in a straight LAO view. Now, moving on to the next screen. Now, that's just me telling you that you need to look at certain structures, vertebral column, ribcage direction and inclination, diaphragm, recognition of LED and PDA. We'll come to that. But let's look at the other view. Just look at this other view of the right coronary artery. Now, what do you see here? I'll just pause for a second. So what do you see here? Again, this is our catheter. And again, it's in the left upper part of the screen, and it's injecting to the right coronary artery, which is assuming this course. But what you see here at the bifurcations become much clearer. So you can see the PLV branch going this way, and the PDA, the RPDA, the right posterior descending artery, going this way. Now, this, and also, if you look at the diaphragm earlier on, we could only see the diaphragm occupying less than half of the screen. Now, when you look at the diaphragm, let's just try and see if we can play again. The diaphragm is here. Sorry, it's here. All of this is a diaphragm. Can you see it? You can see it moving at its own pace, not moving with the heart, because it moves with respiration. So when you see the diaphragm occupying most of the screen, or more than half of the screen, then you're looking at a cranial view. The vertebral column is here, and the vessel is almost overlaying the vertebral column. So this is a PA cranial view. It's a cranial view because you're seeing the diaphragm occupying most of the screen, or more than half of the screen. So I'm not sure how clear is this, or whether you can see the difference. I'll just go back to that view again of the right coronary artery. So you can see the difference. Let's just see if we can get this to play. This is the straight AP view. See those two vessels overlaying each other here. And you don't see the bifurcation very well. And the diaphragm is only occupying sort of a little bit of the screen, not most of it. So going forward here, this is the view we just been looking at, and the bifurcations become wide open, and the diaphragm suddenly occupies more than half of the screen. Right, I hope it's clear so far. We'll move on in the interest of time. Dr. Hatim, how much time do we have?
Don't worry about time, just carry on. We still have maybe 45 minutes.
Okay, good. Right, now look at this view. Now this view, I'll just pause it here. Now you're looking at a different structure. This clearly is not the right coronary artery. It's a vessel that starts as a single trunk and it bifurcates into two big vessels. The catheter is still on this left upper corner of the screen, but it's pointing this way, not this way. And the heart is here. So looking at this, and you can see the vertebral column up there, and the rib cage inclination is this way. And try and see the diaphragm. You can still see movement of the respiration, but you don't see the diaphragm. You don't see the diaphragm. And of course, this border here, this convex border, this is the heart itself. So don't mix it with the diaphragm. And if in doubt, just watch the movement of it. It moves as one. This is the heart. So when you don't see the diaphragm completely, then you're looking at a chordal view. Chordal views don't show the diaphragm. And chordal views mostly reveal the circumflex artery as opposed to the LAD artery. So what you're looking at is you're looking at the left coronary system on a chordal view. We call this LAO caudal, so left anterior oblique caudal view. And we have a different name for this view. We call it spider view because the vessel looks like a spider in this view. So left main stem, the vessel that is on the left side most, this one going this way, all the way, there's nothing left to it. That's the LAD, left anterior descending, in this view. And the vessel that's going on this side, this is the circumflex, the left circumflex coronary artery. Now, why couldn't this be the circumflex? Because this is coming from the LAD, because the left main stem is short, it divides into two vessels, LAD and circumflex, right? So whatever branch that comes of this vessel afterwards, that's an obtuse marginal vessel. So it has one obtuse marginal vessel here and several others on the other side, which we can see on other views. Now the LAD on this view is foreshortened because it is going away from us towards the apex. You don't see it very well, and you can't appreciate the LAD in this view very well, particularly the distal and the mid parts of it. You can appreciate the proximal part of the LAD in this view, as well as the left main stem and the circumflex, but not the distal or the mid LAD. Right, so this is an LAO caudal view of the left main system, of the left coronary system. Let's just play it again, just for people to have a look at. And I'm just gonna move to the next view. Now this is a different patient, but looking at this view, again, it's the same caudal view, but it's not the same caudal view. It's a caudal view. We call it an RAO caudal view. And again, looking at this, can you see the diaphragm? Just a little bit of it here, very, very tiny bit of it. Certainly doesn't occupy a lot of the screen. And maybe the reason for that is this is not a sort of a deep caudal view, it's just almost a straight PA view. And sorry, I'll just let it play. 1 second. Yeah. And as I said, chordal views show the circumflex system. So this is the circumflex coronary artery going down here, and it's giving one obtuse marginal branch coming off here. The vessel that you see going away in the background and becoming convoluted here is the LAD. So the LAD is always foreshortened in the chordal views. So you can't make a lot of judgment on the LAD here. Now, moving forward, look at this view. Now, is this a cranial or a chordal view? Now, the way of knowing is you look at how much of the diaphragm you're seeing or occupying the screen. Now, this is a cranial view. The reason why it's a cranial view is look at this diaphragm. Look how much of the screen it's covering. Almost most of the screen is covered by this diaphragm. So this is a cranial view. And as opposed to chordal views, cranial views tend to extend and stretch the LAD. So you see the LAD better in the cranial views. And the circumflex becomes foreshortened, and it is thrown to the sort of periphery of the screen. So what you're seeing here, this is a circumflex vessel. And what you're seeing here, the vessel that is occupying most of the screen, this is the LAD. The one that was earlier foreshortened and not quite visible, now it's visible here. Now, in the LAD, on all the cranial views, the vessels, the branches of the LAD that come off this side of the LAD, going to this side of the screen, these are called diagonal branches. So one diagonal branch, small diagonal branch here, another diagonal branch here, another small diagonal here, another small diagonal, and the LAD goes all the way to the apex. Now, the branches on this side, these are the septal branches, the septal perforators. So septal perforators always on the cranial views are on this side of the LAD. All of these are septal perforators. They go down and penetrate the septum. And the only vessel that gives septal perforators on the left system is the LAD. Of course, the other vessel that gives septal perforators is the RPDA, or the PDA, posterior descending artery. Often comes off the right coronary artery if it's dominant, or it can be a branch of the left circumflex in a dominant circumflex system. Now, this is another view. And again, we're going to ask the same question. What view is this? And again, you look at the diaphragm. Now here, look at, there are two borders. This border here, you see this border here, this is the heart border. You know it's the heart border because it moves with the heart. And this border here, this is the diaphragm. And as I say, it occupies almost all the screen. And you see it, and you look at it when it's moving, and you know it's moving at a different pace. So that's the diaphragm. So this is a cranial view again. I'll just play it again. Just watch those two borders here. Because you can see one is the heart, it's clearly beating with the heart, and the other one is the diaphragm, because it's moving differently. And because the diaphragm occupies all the screen, it's a cranial view. And because it's a cranial view, the vessel that is most visible on the cranial view is the LAD. And this is a PA cranial view. So what you're seeing here is the, RA cranial view. What you're seeing here is the LAD. And again, this is your diagonal. Diagonals are going always this way, this way, this way. And septal perforators are going the other way. So several septal perforators, several diagonal branches. This vessel here, the LAD, reaches the cardiac apex, and it goes a little bit underneath the apex as well. I'm not sure if I'm making sense so far. I hope I am. So
I think you are.
Thank you very much. I'll just move forward. Now, I'll just ask a question. I know the others perhaps are muted, but this maybe just a little bit of small homework to the others. What do you think this view is? And which vessel is which? I'll just stop it there. So again, you try and see, is there a diaphragm visible? And you look and see there's no diaphragm visible. There's only just the heart border here. You can't really see the diaphragm. You can see the respiratory movements, but you can't see the diaphragm. Also, the vessel is bifurcating immediately, and it does look like a spider. So this is an LAO caudal view of the left system. This is the left main stem. This is the LAD. We said that the vessel that goes on the left side the most on the spider view is the LAD. So this is the LAD. This vessel coming as a branch of the LAD here is a diagonal. So in the spider view, diagonals come off this way, and septal perforators come off this way. And this vessel here is the left circumflex, and it's going this way. It's giving rise to an OM branch here. Now, moving on to this other view. Now, yeah, this is one of the patients who came to us in cardiogenic shock. As you can see, this is a spider, but all you see is just a left main stem, and the LAD is occluded fully. And the circumflex is also occluded, apart from this little branch here, AV circ. You also see that this patch here that you see, this is a defib patch. You know, the defibrillator pads, because he came as a kind of a major anterior STEMI, and normally these people, by the time they get into Cath Lab, they have the defib pads on. We went femoral, as you see. The earlier images that we see, we had, I'll just go back to this one, for example. Just let it play. Now here, you're seeing the catheter coming from here, but you're not seeing anything on this side. So you know that this is a radial procedure because you don't see the other part of the catheter here. But if you move to this one, you can clearly see the catheter coming up here from this side. So you know that we went femorally here because the guy didn't have any blood pressure. We couldn't feel the radial pulse. And he had almost all his left system gone. And to make it worse, that's his right system. And because miracles do happen, this is one of the guys who were lucky. It wasn't his day, so he managed to open those vessels, and he's alive and well 6 months later. This is the right coronary artery, as you see. It's completely blocked here, and you don't know which position this is. It's an LAO view. The diaphragm is here. You can't see it, so this is a straight LAO view. Right. Now, again, looking at these vessels, what do you think this view is? And you look at this, and this is a left system, and this is a femoral procedure because you can see the catheter going up here, and you see the injection circumflex going this way. You know it's a cranial view because the diaphragm is occupying more than half of the screen. So you should see an LAD, but instead you're seeing just this vessel here, this little either high OM or high diagonal branch. You can't see the origin of it. But what you don't see is you don't see an LAD coming all the way down here like it should. So this is an anterior STEMI patient who came with a blocked LAD, and I'm just showing you this. I'll just stop it here. What you're seeing, sorry, just going to see if I can stop it. Yeah, good. So what you're seeing here is this is just, some of you may know this device. This is an intra-aortic balloon pump being positioned. You can see the wire going up through it. That's a device not yet operated. When you insert it, you want to make sure that the tip of it doesn't go beyond the aortic arch, so it just stays in the descending aorta. And when it's operational, you will see it, you will see it inflating and deflating. And as you see, it's meant to augment the blood pressure in people who come in with coronary ischemia, cardiogenic shock, and low blood pressure. So this is meant to augment the diastolic blood pressure and improve coronary perfusion, because coronary perfusion is diastolic. So this is what an intra-aortic balloon pump should do and behave like. You see the balloon here inflating and deflating. I hope it's clear to you. Now, I've spoken a lot, so I'm going to leave some time for questions. So please, if you have any questions about the talk or about some other aspects that I should have covered but I haven't, please please let me know, and I'll do my best to help. Thank you. Can everyone hear me?
Yes, Dr. Talal, thank you so much. It was really brilliant, a great introduction to Cath Lab, and it's so encouraging actually. And I think you, ladies, gentlemen, if you have any questions, Dr. Talal is here, so try to seize this opportunity. We might not get him easily back. So, yeah, now you have a chance to interact and ask questions if you wish.
يا حاتم السلام عليكم. حاتم طلال السلام عليكم.
عليكم السلام ورحمة الله.
Dr. Abdurrahman, how are you?
أهلين وسهلا، كيف الأخبار؟
Honor to have you here.
أيوة والله شكرا جزيلا. طلال والله يعني صراحة very excellent presentation talk, very informative and very useful.
مشكور دكتور عبد الرحمن.
I don't know allowed يعني to ask and to comment وكده.
Of course بالتأكيد.
Yes, sure.
أوكي طبعا.
لا of course you are.
طبعا is not our area وكده intervention. لكن just when I remember when we were preparing يعني for the fellowship exams وكده طبعا عندنا بعض الطرق كده جلبندية زي ما تقول يعني كده for non-interventions عشان نذكر بها وكده الفيوز. فأنا just يعني will mention some يعني tricks وتيبس كده for non-interventionist كنا بنذكر بها نعرف بها الفيوز وكده. و I need your comments يا طلال في النهاية يعني وكده.
جدا.
أول شيء بالنسبة للبنكشر you did mention this during your talk إنه بالذات في البداية مثلا بتذكر لما كنا هو يعني بنمشي الكاث لاب وكده فبنركز على قصة الارتري فورسبس اللي بنحطها على الهيد اوف ذا فيمر. وفي بعض الانترفنشنست يعني they don't do cath without I mean putting بالذات بالنسبة للبنكشر يعني بيحطوا اللي هو ارتري فورسبس على الهيد بتاع هذا و they go يعني باي فلورو وكده. بتذكر عندنا دكتور اسمه زرار مالك الله يرحمه توفى وكده.
الله يرحمه.
دائما يعني he's doing this يعني. فما بعرف انت in your practice بعد ما الواحد يبقى يعني expert وكده they don't need this one he doesn't need يعني to put this one as a marker as landmark وكده تمشي به وكده ولا لا؟ or do you advise the number one? number two طبعا بالنسبه لي زي ما قلت لك التريكس يعني مثلا انا كنت بيرسونالي ايوز ات عشان اعرف الفيوز وكده. بشوف الفيرتبرال كولوم او السباين اوكي اذا كان السباين towards my right hand this is LAO. اذا كان towards I mean the my left hand this is RAO. اذا كان في النص this is AP ولا PA whatever. اوكي this is number 2. number 3 بالنسبه للكودال and cranial صح الديافراغم وكده is very good لاب مارك وتعرف به وكده. لكن كنا بس يعني لو شفنا مثلا البايفوركيشن is very clear يعني is open up البايفوركيشن and if you are looking from down okay this is caudal. if you don't see المين فيزل انا بتكلم عن المين فيزل مثلا يعني ال LED مثلا والسير well separated اوكي مفتوحات وبعيدات من بعض وكده this is caudal view. لو overlap مع بعض وما فاتح الانجل بيناتهم وكده as if you are looking from up this is cranial. okay this is just يعني quick tricks and tips كده we used to نعرف بها الفيوز وكده. طبعا في بعض الفيوز واضحة جدا اللي هي يعني السبايدر فيو is clear you cannot mix it مع أي حاجة ثانية. وال LAO cranial view بالنسبة لل LED اللي بيشوفوا ال LED طويلة وكده برضو يعني واضح. والتريكس الاخير الاخر تريك انه في ال AO بتشوف الهارت كانه جلوبيولار دور كده، اوكي. لكن في ال RAO as if you are cutting الهارت على اللونج اكسس بتاعه، اوكي، elongated something like that. This is just يعني few comments. طبعا is not necessary تكون scientific وانها تكون صحيحه وكده، لكن just بعض الحاجات كده اللي كنا بنتساعد فيها انه in our preparation انه how to know quickly كده بصوره سريعه، و زي ما قلت لك is not يعني necessary انها تكون scientific وكده. فجست I need your comments على الحاجات دي بالنسبه للفلوز، عسى ولعل يستفيدوا منها يعني لو صحيحه يعني.
والله أول حاجة عبد الرحمن دي إضافة جميلة جدا جدا وأنا أشهد بها كويس و mostly true. أول حاجة بخصوص موضوع الارتري فورسبس وإنه تحطه في الفيمورال هيد عشان تعمل ايميجينج وبعد ذاك تبانكشر، دي طبعا فيري سيف ما في كلام. وانا شخصيا اي ريزورت تو ات whenever I feel انه حيكون في difficulty، يعني البيشنت يكون اوبيس شويه او I can't feel البلس comfortably enough عشان to puncture it. لكن في الحالات اللي بيكون فيها البيشنت of average size you feel the puncture, you feel الفيمورال and you can sense clearly انه ده الفيمورال انا شايفه وعارف انه حخش فيه، و you can even compress it على البون ستراكشر تحته بتشوفها بتحسها يعني. في الحاله دي I don't need to necessarily put an artery forceps عشان to puncture، لكن it remains the safest practice انك لو عندك كمان ultrasound عليه يكون added safety. ف this is very valid و very good and I recommend it especially if you are not sure about the puncture or if you can't feel it confidently. بخصوص الvertebral column والposition بتاعه compared to the vessel, again this is mostly true. انا ما ذكرتها لانه sometimes البوزيشن حق الهارت ذاته بيكون swayed باللنكس، والزول مرات بيكون ما قاعد بصوره كويسه في السكرين، فلو اعتمدت عليها كومبليتلي هي موستلي رايت، اوفر 90% اتوقع انها رايت. انه الفيرتبرال كولوم دكتور عبد الرحمن بيقول لو كان ان ميدل والارتري طوالي اوفرلينج معناها ده اي بي فيو، اذا كان تو ذا رايت اوف ذا سكرين معناها this is an LAO view، اذا كان to the left of the screen معناها this is an RAO view. ده كلام صح ما في كلام، لكن ما على اطلاقه لانه في بعض الحالات تلقى لك حالات مجغمسه كده. النقطه التاليه ذكرتها يا عبد الرحمن، ذكرتها دقيقه اتذكرها يا ربي كان شنو، ايوه السيبريشن بتاع الفيسلز. واجين this is mostly true انه لو فعلا في كودال فيو بيكون دي والسيرك كبير، ولو كان كرينيال بيكون السيبريشن almost بيكونوا overlapping each other. لكن again this is ما على اطلاقها، بتلقى لك حالات مجغمسه، مرات تلقى السبايدر تضرب تفتش الانجل عشان تعمل سيبريشن ما تلقاهم مجغمسات مع بعض، والعكس برضه بيكون صحيح. لكن برضه يعني mostly true very good point ما في كلام. النقطه الرابعه ذكرتها انا نسيتها صراحه، ذكرني عليها عليك الله.
والله تاني ما في حاجه كده، اظن قلنا السبايدر فيو واضح جدا، ما اظنه يعني you can mix it with anything else. بتبقى بس طبعا تجي difficulties في حاله الانوماليز كوروناري انوماليز وكده، فما بعرف هل بتتعرض لنا لها فيما بعد للشباب ديل لانه
فيما بعد ممكن اي
بعض انا عارف انها سيبريت يعني كده وهنا، لكن اديشنال لكن زي نيدد صراحه، لانه بصراحه يعني sometimes بيطلبوا مننا بعض الكيسز وكده وهذا، ف we used to give them يعني anomalies اوكي، ف is not خباثه مننا لكن او to make it difficult، لكن I think is needed because they face يعني these cases يعني it is not something advanced.
ما في كلام. في انوماليز عندنا كثيره، في انوماليز تلقى اول حاجه الليفت مين ترافوركيتس لكل الفيسلز بيطلع من ليفت مين واحد، ومرات بيكون بيطلع الليفت مين ذاته من الرايت، ومرات بيطلع الرايت من ال دي، يعني قصه مجربه ممكن تكون. فمرات تلقى ديكستروكارديا ما تعرف تخش لها كيف ذاته، لكن طبعا رير، لكن ات هابنز ومفروض الناس تكون بريبيرد لها ما في كلام. طبعا this is a different talk.
والله يا اخي بدايه جميله جدا جدا صراحه، ويعني مشكور على المجهود ده وكده، وحاتم يعني صراحه دائما مبدع ودائما مفيد للناس وكده، فاتمنى انه يعني الحكايه تستمر وكده. صراحه الواحد يعني استمتع برضه يعني بالوجود.
بعدين طبعا يا دكتور جميل، نحن I think you are warming up، لانه after that you have I think you are on the line. Okay.
انا في اللاين لكن اخر شايف في اخر شرف
لا اللاين
حكم شرف
بنجيبك قدام ثاني.
لا ما عندك مشكله، ما عندك مشكله.
This is
بعدين
great.
بالمناسبه يعني احنا اهو من تحضيرنا كده وبتاع للفيلوشيب، الواحد لسه بيتذكر التيبس والتريبس بتاعت الهيموداينامكس ومش عارف الاي سي جيز في كل حاجه كده. بتتذكر يا حاتم انت لما كنا بنجيكم هناك
طبعا
عسكري وكده.
exactly.
يعني
This is great والله يا دكتور طلال. بس دكتور طلال بس I just want to ask two quick questions لأنه I don't see يعني our fellows are having questions. One is الآن the femoral the radial axis is the default axis. I just want to know يعني out of curiosity how much you convert to femoral and in which situations. Okay. الحاجة الثانية برضو I want to ask about when you are imaging the coronaries, when you focus at the proximal portion of the artery versus the distal portion, how are you going to navigate your camera? Just again, if you can. Okay. Thank you, Dr. Talam.
الله يسلمك يا دكتور حاتم. أنا الجزء الأول من السؤال اللي هو بتاع دخل في فور ديمنشن. تذكر الجزء الأول من السؤال
اللي هو الفيمورال axis how much you need it. Yeah.
الفيمورال، شوف الفيمورال يعني أنا I don't like femoral. I hate it. ما بحبه. لكن I recognize إنه it can't be obsolete. يعني في حالات you have to go femoral فيها، ما في كلام. يعني مثلا أديك مثال، في جانا قبل فترة بسيطة patient بانتيريور ستمي والراديال بلس حقه سمحة جدا جدا. دخلت راديال لقيت إنه عنده separate ostia للليفت مين، ما عنده ليفت مين، يعني عنده separate ostia دي براه اللي هو المقفول كله والسيركمفلكس. الكاثيتر دائما بتنجيج للسيركمفلكس، قدر ما غيرت الكاثيتر مرتين ثلاث بتخش السيركمفلكس، ابد تخش ال دي كله. ونحن وي ار ريسنج اجينست تايم، ال دي مقفول. فلو كان في حاجه يعني مثلا كيس يعني كولد كيس وكده والعيان ستيبل، كنت ممكن استنى شويه بحرف انا بتاع احاول اخش لكن هنا ما في وقت. ف this is one of the cases we had to convert to femoral. اول ما خشينا femoral الارتري الكاثيتر براها خشت ال دي. فده مثلا ده مثال. في امثله ثانيه طبعا، انه بيجيك العيان بتاع الكارديوجينيك شوك اللي هو يو كانت فيل ذا راديال بلس، اصلا ما في راديال بلس والفيمورال فيبل جدا. ففي الحاله دي بتخش فيمورال احسن لك، لانه في النهايه الفيمورال ذاته بتستخدمه للبالون بامب اسرع. في other situations تلقى العيان مثلا عامل له باي باس اوبريشن وشايلين الليفت راديال، واصلا عامل له يعني ليما، فانت عشان تخش الليما ده تشوفه ما بتقدر تخش بالرايت راديال، لانه قصه صعبه حتكون بعد ذاك نافيجيت الاورتيك ارش وتنزل وتطلع ثاني بالغالب. فيو هاف تو جو فيمورال لانه الليفت راديال السيرجن شاله. فدي بعض الحالات اللي انت بتضطر تعمل فيها تخش فيها فيمورال. في حالات ثانيه اللي هي الكونفرجن، انت سالتني عن الكونفرجن تكونفرت كيف. فممكن تلقى انه في الزول ده عنده a lot of loops في السبكليفين حقته، السبكليفين يكون ملولو جدا. فباي ذا تايم انت الكاثيتر حقك تتلولو في اللوبس حق السبكليفين لحد ما تخش الاسندنج اورتا، ما بكون عندك توركينج ابيليتي، فبتحاول تلفها بتتلولو فوق في السبكليفين ما بتقدر، فبتضطر تقوم تخش فيمورال عشان تكون الدخل له سهله. مرات بيحصل لك راديال سبازم، الراديال يحصل له سبازم والبيشنت يخش في بين وبتاع، ما تقدر غير انك في النهايه تحول لفيمورال. لكن طبعا كل الحالات دي are not very common. يعني انا بقول لك الفيمورال بتاعي less than maybe 2% 3% at the most.
اوكي.
معظم الحاجات الشغل بتاعي ريدي.
السلام عليكم.
Great. Thank you دكتور طلال. Yes.
السلام عليكم.
عليكم السلام ورحمه الله وبركاته.
اهلا وسهلا.
شكرا جزيلا دكتور حاتم ودكتور طلال ودكتور عبد الرحمن الكومنت. انا دكتور ياسين فيلو.
اهلا ياسين، كيف احوالك؟
الله يسلمك. Just I want to ask a small question. لما يكون مرات عندنا patient very obese فبيكون عنده belly abdomen راقد كده على الفيمورال، نحن كمان بنشتغل بالفيمورال لاينز يعني، واحيانا بعد ما تعمل تدخل الكاسيتر وتقدر تعمل انجيجمنت او عملت انجيجمنت وتدي الضاي، فبيكون الصوره في السكرين بيكون هيزي، ما بتكون شايف الارتريز كويس. فهل في اي يعني procedure can be done that to make the screen more clear for us؟ انا ما اعرف ده عشان الفات around the abdomen or what بيخلي السكرين very hazy. فشنو
أيوة.
ممكن نعمله عشان نخلي الصوره اوضح بالنسبه لنا اكثر؟ ده سؤال. السؤال الثاني يعني بالراديال، يعني ممكن يكون بروكسيمال راديال او ديستال راديال، فليه الناس ما بتخش بالبريكيال؟ يعني why is it contraindicated to go through the brachial or what؟ يعني الناس اختارت الراديال ليه وما اختارت البريكيال؟ شكرا جزيلا.
الله يسلمك، سؤال جميل جدا يا ياسين. السؤال الاول اللي هو موضوع الزول الاوبيس، ولما تاخذوا الاكوزيشن بتاع الصور بتكون هيزي وما بتكون واضحه كويس، فتعملوا شنو؟
Yes.
ففي حاجتين ممكن تتعمل، اللي هي انك تكولوميت، يعني عشان تفوكس الاكس راي بيم اكثر، بدل ما تخلي السكرين كلها فاتحه على مصراعيها تخلي الشطرز تنزل بالجنبتين وبفوق، على اساس تفوكس البيم حقك كويس. ده نمره واحد. نمره اثنين، انك تو انكريز الفريم ريت، الاكس راي فريم ريت. معظم الكات لابس الاكوزيشن فريم ريت بتكون يا اما 10 او في الكات لابس الكويسه بتكون 7.5، بتكون الاكوزيشن فريم ريت صغير جدا. فلما تزيد الفريم ريت يعني ممكن تخليه 15 او 30 فريمز بير سكند. فلما تقول للراديوجرافر اللي معاك يا اخي اسمع اعمل كولوميشن كويس، وبعدين زيد الفريم ريت ل 30 فريمز بير سكند في الاكوزيشن الجاي. طبعا you don't want to do it all the time لانها بتزيد الاكس راي يعني اكسبوجر كويس. وبعدين قرب الايمج انتنسيفاير للعيان، ما تخليها بعيده كويس، خليها قريبه منه جدا. فدي ثلاث حاجات ممكن تعملها على اساس تخلي الصوره شويه واضحه. الحاجه الثانيه، حاول ابعد من الاوبليك فيوز. يعني مثلا لو عندك السبايدر بتاع الزول ده حيكون شويه هيزي اكثر من لو كان عملت له اي بي فيو، اي بي كودال فيو مثلا، او اي بي كرينال فيو. الاي بي كودال والاي بي كرينال فيوز بيكونوا اوضح كثير من الاوبليك فيوز.
تمام.
ده فيما يختص بموضوع الراجل اللي بيكون سمين والصور حقته هيزي. اما السؤال الثاني اللي هو راديال بريكيال، ليه ما بريكيال؟ لانه البريكيال اند اون ارتري كويس. واصلا الانجيوجرامز لما بدوها الناس في الستينات والخمسينات بدوا بالبريكيال، ما بدوا بالفيمورال. يعني الانيشال تكنيك حق الانجيوجرامز كان بريكيال، لكن الوقت ده كانت كرود وكانت ما يعني سوفيستيكيتد، والكاثيترز حقتهم كانت تعبانه، وكان في a lot of complications compared لهسه. وجزء من الكومبليكيشنز كان بيحصل اسكيميا لليد، فبيحصل ليمب اسكيميا، لانه البريكر لو بتحصل له مصيبه ما عنده ارتري ثاني بيغطيه. عكس الراديال، انت لو الراديال كله انتهى في النر بيغطيه، عنده لوب جاي بيغطيه ما في مشكله.
يس.
حتى السيرجنز بيطلعوا كله بيستخدموه للجرافتس. فعشان كده يعني البريكل بقى فيري ان فيفورت، ما فيفورت كله انه تستخدم بريكل. يعني لو اصله غلبك الراديال امشي فيمورال، ما تمشي بريكل.
يعني ممكن
الفيمورال اند ارتري لكن كبير يستحمل، لكن البريكل لانه صغير لو حصل فيه اي حاجه ممكن تدمج الارم. ده
اوكي
يا طلال ايوه النقطه بتاعت ياسين دي ذكرتني، يعني برضه بوينت افتكر انها مهمه. في نلاحظ يعني في اور كومباين ميتنج مع الكاث سيرجيكال ميتنج وكده، when they show the cath كوروناريز بتاعت البيشنتس وكده، التشيرمان بتاعنا اللي هو انترفنشنست فيري سينيور دكتور زيبق، معروف يا حاتم مش كده؟ ف يعني الله قال بيقولوا الانترفنشنست اللي بيوري الكاث ويكون الديافراغم ظاهر في الكاث، دايما بينتقدهم في الحته دي. بقول لهم انتم المفروض لما تعملوا كاث واسك البيشنت يعني تو تيك بريث عشان ينزل الديافراغم تحت. لو بقى الديافراغم ظاهر في الكوروناريز في الفيو يعني بينتقدهم بشده. انا ما اعرف هاو. وبعدين الان احنا بنستعمله از لاند مارك عشان نعرف به مثلا الكودل ولا كرينيال وكده. فما البوينت دي انت تعلق على شنو؟ واحده من الحاجات اللي زي ما قال ياسين مثلا بتكون هيزل كده الايمج وكده، لانه الانترفنشنست doesn't ask the patient to take deep breath مثلا، عشان يعني مثلا نحن بنستعملها في الايكو برضه. يعني في الايكو مثلا في الابيكال فيوز احيانا انت عصلج معاك خالص ما تجي، بتكون فيري هيزي وكده وفيري بليري يعني الفيو. ف we ask the patient يعني to take breath ويعني to hold in expiration مثلا. ما بعرف هل how to do الكلام ده.
والله هذا كلام جميل يا عبد الرحمن. عارف ذكرتني كان الكونسلتنت بتاعي تعلمت معاه اول ما تعلمت معاه، مش اول واحد، هو ثاني واحد، اسمه ستيفن سالتيزي. فواحد من السينيور كارديولوجيست وكان بيتبع نفس الاسلوب ده. هي دي ريفلكس السينيوريتي بتاعت الراجل زولكم ده، واضح انه زول سينيور قديم. فال at that stage او الجنريشن ده كله تعلم بالطريقه دي، انه انت يا اخي to take a deep breath و hold the breath، بعد ذاك they inject. يعني never inject والبيشنت بيتنفس ساكت عادي كويس. بعد ذاك ليتر اون بقت الحكايه دي ما مهمه شديد، لانه الاكس راي اكويبمنتس الايمج انتنسيفايرز بقت سوفيستيكيتد اكثر، الكولوميشن بتاعها احسن كثير بقى، وزي موضوع البيكسلز حق التلفزيونات الجديده دي، يعني تقارنها بزمان وهسه فرق كبير. فبقت الحوجه لانه الزول يمسك نفسه وبتاع، هنا يمسك نفس نزل النفس بتاع، بقت ما في داعي لها.
والنقطه
الكواليتي ذات فيري ماتش.
والنقطه الثانيه وين يو دو كولومينيشن دي مع الفريم ريت اوتوماتيكلي تخيل لي بيزيد. نحن بنلاحظها في الايكو مثلا وين يو ريديوس السكتر ويدث اوتوماتيكلي الفريم ريت بيطلع على طول. انت يعني ما حاجه انت يعني اسمه شنو تنكريز مثلا الفريم ريت بايور مثلا في بطن معين تزيده انت مثلا مانيوالي.
لا تخيل في بطن تزيده مانيوالي، عندك certain frame rates you can select الفريم ريت اللي انت عايزه من غير الكولوميشن. الكولوميشن براه والفريم ريت براه.
لا اي مين انه وين يو دو كولومينيشن ما بزيد الفريم ريت اوتوماتيكلي؟
ما بزيد لا، لكن it reduces السكاتر كويس. فالسكاتر ده براه بيعمل هيزنس للصوره، لكن لما تكولوميت السكاتر بيقل، فده بيصلح لك الايمج كواليتي بنفس الفريم ريت بتاعك. يعني بالعربي بيعمل لك اوبتمايزيشن للفريم ريت حقك، يعني it gives you the best image of that frame rate.
ماشي.
لكن لو زدت الفريم ريت حتزيد زياده.
اوكي ماشي. معناه عندنا بيختلف شويه من عندنا في الايكو.
لا بيختلف عندكم الايكو طبعا، لانه كمان انتوا اللنجز بتجيت ان ذا واي، لانه انتوا الترا ساوند. فلما تقول لزول وقف النفس التنفس بيجيب، فيو كان جيت ذا ايمج كلير وثابته.
صحيح.
ما بتكون ان اور اوت اوف فوكس، ما زي
مظبوط صحيح. يلا والله شكرا لكم يا شباب.
ثانك يو سو ماتش.
مداخلاتك جميله جدا بالمناسبه.
والله يعني المداخلات بتاعت انترفيشنست يعني كده حاجه
رائعه والله.
جربنديه زي ما تقول يعني.
حرام عليك جربنديه.
استاذنا جميعا دكتور جميل.
والله بالعكس يا ما عليك زود، ما عليك زود زي ما بقول. اسمع ما عليك زود زي ما بقول السعوديين يا حاتم. العين ما تعلى حاجه والله.
الله يسلمكم
دكتور حاتم.
لا والله نحن يس
ممكن اطلب طلب؟
شوف
احنا بس يعني اذا ممكن عايزين لكشر عن التايب اوف كاسيتر وين تو تشوز يعني the catheter which will be more suitable for a certain patient. يعني مثلا لما يكون في long patient different من الشورت patient وديفرنت من الاوبيس الثين. والحاجه الثانيه عايزين لما نعمل انجكشن للضاي اذا كان البيشنت مثلا عنده اوكلوشن فور لونج تايم وعنده كولاترالز، عايزين نعرف الكولاترال مثلا ريتروجريد وانتجريد وابسيلاترال وكونترالاترال، فمهمه دايرين نعرف الحاجات دي. يعني التايبس اوف كاسيترز والكولاترالز مهمه بالنسبه لنا اذا ممكن يعني.
وطبعا دكتور طلال was actually ready to present whatever in this interventional field، ولكن نحن we insisted انه the initial presentation to be more of introductory and more of basic، لانه ماشيين ببيزك موديول. لكن I assure you ياسين ان شاء الله ودكتور طلال معانا هنا more of technicality and more of the questions you have asked to be answered next session مع دكتور طلال. definitely we will have him in more and more sessions about the details of technical approaches وكل الترابل شوتينج في الكاث لاب وغيرها، حتى الراديشن والراديشن سيفتي والانترفنشنال بروبلمز وكل الاشياء دي ان شاء الله حيكون معانا فيها و don't worry about that.
ان شاء الله. شكرا جزيلا.
دكتور طلال you agree with that؟
I agree، ما في كلام. طبعا هو it is very difficult to cover all of those topics in one talk. يعني مثلا الكثب الشيبس والتايبس دي دايره لها توك او اكثر براها، والراديشن سيفتي كمان قصه طويله، السي تي اوز او الكرونيك توتال اوكلوجنز الفلو تخش كيف تطلع كيف، في كمان ريتروجريد تكنيكس، يعني دي ادفانس شويه لكن برضه ممكن نغطيها. ممكن يعني anything that you feel needs to be covered انا ما عندي مانع we can cover it ان شاء الله.
ان شاء الله. جزاك الله خير.
تمام
الله
تمام
يسلمك.
جدا.
شكرا.
وشكرا جزيلا لكم جميعا. Thank you so much دكتور طلال. Thanks a lot.
Thank you.
Thank you for your attendance and see you next week إن شاء الله.
شكرا دكتور. شكرا دكتور حاتم. جزاكم الله خير. شكرا.
جزاكم الله خير دكتور حاتم، دكتور طلال، دكتور عبد الرحمن، ان شاء الله في ميزان حسناتكم يا رب.
الله يسلمكم إن شاء الله يا رب.
الله يسلمك ان شاء الله.